Good afternoon, everybody, and thanks very much to the college for the invite. My presentation is going to be hard to follow because that was really, really good. That was really energetic, and it probably spoke an awful lot about what leading and generating integrated care is about. Because as you showed those two circles for the drug strategy and the older people, and having worked on the drug strategy, it's great to see the prisons were up there. Great to see the prisons on the discharge planning from the matter, because we always have a problem about getting to, and that's about, that's hugely about how people think and how we change thinking. And it is that ghettoising phrase, is that, we either ghettoise communities or we ghettoise or we stigmatise people. So, that is a whole facet of how we think about and how we change and how we integrate thinking. In that older person slide, there's one thing I would include, which is older prisoners. Because we have a prison that we shut down last year that we were going to reopen. We're going to repurpose the prison for older prisoners, because we have a huge problem with a massive amount of prisoners who are now quite elderly, who are serving sentences, and despite people like myself going into court saying we find it very difficult to look after these people properly in prison, the judges are saying thank you very much for your kindness and for your worry and concern, but we're still sending them to prison for 10 years. And that, in effect, is a death sentence. So we run a primary care service in prison. We don't run, inpatient care services. We're having to rethink and reevaluate all that. So prisoners need to go in that second slide as well. And there are, at the moment, 5,000 historic sex offences waiting to go through the courts of an older age profile person. So we are looking, from what we had. Arbor Hill Prison in Dublin, with about 120 beds, was the place that we had for sex offenders for many, many years. We had to increase that to 2 wings of the Midlands Prison in Portlaoise over the last couple of years. We're now over 300. So just in terms of, we've gone from like 120 to over 500 in the matter of about 7 or 8 years. That's going to go exponentially. So I'm going to be giving you a call because I want to get you to come in and talk to us around integrating what true care is. Now, I suppose, to start off, I work in healthcare in the prisons, but it is not your typical healthcare environment by any means. Yes, we always put the prisoner or the patient at the centre of what we do. As healthcare staff in prisons, it's so important, and that again comes back to your diagrams, Mary. And the question is, are they prisoners or patients? When we think about integrated care and team building, and we need to be clear: who are we talking about? Who are the people we're talking about? And are they prisoners or are they patients? And from a room full of nurses, it's kind of, who, at a show of hands, who would say they're prisoners? Yeah, go on, put them up high if you think so. Yeah. And who would say they're patients? Yeah. But every time they're in front of a nurse, they're a patient. And that's really important. Not many hospitals look like this. When you walk into environments like these, it can be quite daunting. It can be quite daunting for the prisoners, and for nurses who come into the service, it can be quite daunting. The thing that we have to do, and the whole thing about trying to maintain integrated care, is for nurses not to lose that vision of, yes, these are patients, because it's very easy for people to become desensitised, to the environment, and to fall into what historically has been a fairly rough and ready kind of, service, which is the prison service, and you've got your big bully boy screws and all that kind of stuff. That kind of stuff, through osmosis, can affect people. And how do you bottle that stuff and keep refreshing nurses to say, actually, and keep thinking, these are our patients. So when I say it's not a typical healthcare environment, it definitely isn't. Who's involved? Again, I feel like a copycat. we have our prisoner, and I suppose, legislatively they're known as prisoners, but you've all these people on the outside, who are involved in care. One of the biggest ones we have is the integrated sentence management. Does that work now? Top right-hand corner at 1 o'clock. And that's a whole new department we've set up in the prisons to pull in everybody. Pull in social workers, pull in chaplains, pull in nurses, pull in guards, pull in anybody who may have an influence in somebody's life for post-release. Because from the time they come in, we want to work through their sentence management, and we want to be preparing them for discharge from when they come in. It could be 3 months, it could be 10 years. But you've got to continuously work on that. You've got the courts, healthcare, of course, governors in the prison service. And historically, governors would have been, I suppose, they would have been the custodians of their fiefdom. Because, you know, in legislation, what the governor says basically goes. And we'll come to that in a moment in terms of how you try and shift that. Prison officers, probation, other prisoners, you know, everybody will be aware of the challenges that are in the community, you know, with the gang warfare and the Hutches and the Kinahans and all that kind of stuff going on. That is magnified 100 or 1,000 times in prison. So fellow prisoners are involved in other prisoners' lives as well. It can be a negative way, it can be a positive way, it can encourage them to be part of, you know, and engage in healthcare, or it can discourage them. We get lots of people come in day one, and the amount of people who have been in bad accidents, who have suffered from anxiety, and basically, my GP had me on tramadol and Lyrica and pregabalin, and, you know, so they have it off, and then if they get their prescription, they're not taking it. It's going out, and it's been fed, and it's been pawned off, you know, around the estate. So we've got to be careful. Solicitors, Gardaí, family and psychology services all again play a huge part in the life in the prisons. Where do you start in prisons? So, and where do you start about trying to change and trying to shift and pull people together? As I say, you've got all these people with all very, very different agendas. But what's the core? And you have to come at it from a human rights perspective. If you don't start about talking about the rights that people have, and I suppose over the last 10 or 15 years, that has been a very, very difficult thing to try and champion, to try and push in the prison environment, because prisoners' rights were ignored for so long. You know, we are advancing very much in terms of how we treat prisoners and just in fact of how we see them as part of society, because, you know, the people who are turning up in ED, the people who need the housing, the people who need the, you know, the drug and alcohol policy, or, you know, the healthy eating policies, these are all the same people. You know, they're not different. Prisoners are not a section of society that just come in and go back out and kind of exist on their own somewhere until the next time they come in. So, you know, when you bring it from a human rights perspective, it kind of helps to focus the mind. It kind of helps to make people think, actually, we are working with human beings again. What's required? And you can read lots of literature, and you can do lots of research about, you know, the psychological approach to what you need to do and how you need to pull teams. And I did my one of the best courses I ever did was the Masters in Leadership with the Royal College out in Sandyford a number of years ago. And I spent 2 years, and I had an absolute blast, and I learned so much about how you build teams and you lead teams and you get followers, and you do all the research about it. And it was absolutely brilliant. I have to say, absolutely brilliant. But when you boil it down to, what time are we now? 2:45 on a Tuesday afternoon, and you're sitting in a room and you want to get people to buy into what's happening, what does it actually mean? You can put all the references you want, and you can quote the RCSI and the good Professor Kieran O'Boyle and all these great people. But what do you need? How are you going to make it happen? First thing I think is you need bravery. And as a healthcare professional, you have got to be brave, because you are going to hear the dissenting voices. You are going to hear, oh, but sure, bloody nurses coming in again telling us what to do, doctors coming in telling us what to do. Here come these psychologists with their, more crazy shit going on, and but we're dealing with prisoners, and they don't realise they're trying to kill each other. No, we do realise that. We absolutely do, and we know we've got to be safe, and we know we've got to work in this very difficult environment. But if you don't stand by your conviction, and when you talk to nurses, when I talk to nurses, it's about what comes from in here. That if you are really not, if you don't personally buy into it, and that you believe in what you're doing, and that you believe what you're doing can actually make a difference, that's going to come out in how nonchalant you are about it and how passive you are about it. And holding on to that bravery to say, actually, you might all be laughing at me, guys. And I remember going into Mountjoy 12 years ago when I started there, and people used to laugh, "Oh, Mr. Kelly, how are all your patients?" And that was a laugh for a while, until we set up a couple of units and we started to win healthcare prizes, and we got publications, and then people start to want to work there. How can I work in that unit? And that shifted the culture as well. So but it took you had to put up with a lot of slagging, you had to put up with an awful lot of, sniggering up their sleeves, and people paying lip service. People who were in significantly senior positions, they will stand there and they will say, "Oh yeah, that has to be done, and that's great." But actually the conversations, the back channel conversations they were having was trying to undermine it. So, and I would say to any nurse, regardless of what environment you're in, you've got to be brave. And if you see a patient in the Mater Hospital or in Beaumont or wherever it is, and things are not happening properly, you've got to stand up and be counted. Understanding. I can be quite forceful, I suppose, and put my point across and be very clear on what I think. As anybody who knows me will say, the counterbalance to that is that you also have to understand where other people come from. And, again, I'll keep the context in the prisons because it's a really good example, is that you have prison officers who are working with people who, they have been brought into prison because they found a semi-automatic machine gun on the passenger seat of their car. Now, this person clearly has every intention, if he gets the opportunity with the right person, of using that machine gun and will kill somebody. And if they happen to be stood between that person and a person that they want to get to, be under no illusion. They'll kill the prison officer to get to that person to kill them, because that's what's driving society and the drugs and whatever. So you have to understand that people are afraid, and that people then say, "Oh, here comes Enda again, and he's talking about being nice to people, but he'll absolutely kill you if he gets the chance." So it's about keeping it real and making sure that the work you do works in tandem with what other people's roles are as well. Because as much as I want people to respect what I do, and it challenges a lot of what they think and a lot of what they feel, if I don't respect their role and understand their role, it's not going to work. It's really not going to work. Synergy. When you are brave enough to call it and name it and put it out there, and when you do understand where other people are coming from, you get this synergy, this dovetailing, whatever you like to call it, but it works. And you may not always see it at the time, but when you look back in retrospect, you can say, "Oh God, yeah, that really worked. That was really positive. That was really good, and we actually made progress." You've also got to let other people see that, and you've also got to put it out there and say, "Actually, do you know what? That was a really, really good job. We did a really good job." And that brings me to one of my big bugbears, is that often, and I think nurses are probably terribly poor at this, they talk about, "Oh, my staff and my ward." And I think when you talk about my staff and my ward, I think we're really disrespecting people we work with, because I don't own any staff. I don't own any ward or any prison. It's about the people you work with, the team. And small things like that say an awful lot about your respect for people and how you get people with you. When we set up the high support unit in Mountjoy Prison back in 2010, it was a whole new way of working with people with major mental illness who were in prison, and trying to keep them safe and to cohort them away from being a source of entertainment for other prisoners. And an awful lot of people laughed, and it was a bit like, the hug-a-thug kind of approach, and you're being too nice and all that kind of stuff. Well, actually, when it started to work, and when it was recognised, and we did some research papers on it, and we reduced the amount of time that people spent in seclusion or locked in their own room by 70% in 9 months. There were days I would walk into prison, there would be 10 or 11 people locked in the pads, as they would call it. And they'd ring me up and say, can you get somebody out because I've got somebody else waiting to go in? And it was like this merry-go-round. Now if we have somebody in a pad or in a seclusion room any given day, it's a rarity. And the accountability is that it has to come to me, it has to be verified, it has to be checked, it has to be overseen. And people actually want to go. And one officer who was coming to the end of his career turned around to me and said, if I had known that stuff like this could have been done 20 or 30 years ago, I wouldn't be bitter and twisted. I'd want to stay on and I'd want to continue working here. So that's the synergy, that when you work with people and when you understand where they're coming from and you treat them in the right way and you're inclusive. And, when we made the publications, there were prison officers who were cited as authors in the publications because they actually contributed as well. It wasn't just the doctors and the nurses and the managers that were kind of wheeled out. When we got the prizes from the WHO and people like that, it wasn't just myself and the consultant who were wheeled out. The prison officers came as well. And everybody, and now that changed a huge way of how we want to work and how we do work. Tenacity. You will get setbacks. You'll regularly get setbacks. You get setbacks from the most unexpected sources. Somebody will take it to court. We get sued on a regular basis. We are the new ambulance chasing. So, we're in court a lot, and then there'll be some precedents that somebody brings up from somewhere and saying, oh no, you can't do that. But I think if you really believe in what you do and you know you're doing the right thing, and you go then and you do as much digging and as much as research as anybody else and stick with it, you'll find the way around, you'll find that you will come out the right end and that it will work. And, people talk about tenacity and they say, oh, you've got to be dogged. Yeah, you do have to be dogged. Say you've got to be stubborn. Yeah, you do have to be stubborn. Say you've got to challenge people. Yeah, you do have to challenge people. But when you bring that back to the bravery and the understanding, and it goes back to that graph with the prisoner in the middle. You keep the prisoner or the patient at the centre of everything you do, you're never going to go too far wrong. Touch wood, I'm nursing 30 years in 1 month, and I've never gone wrong by keeping the patient at the centre of what I do. And I think that's, if we do that, we're really holding on to that big time. Education and research. I did mention at the start, I had a blast for 2 years doing a master's, which was hard work, but it was really, really good. And I think if you get people back into the education and research bit, you can't progress unless you can stand over what you do. It can't be, Enda Kelly's had another great idea and we're going to run with that because it sounds great and he can say it really well and he can sell it well. I'm not a salesman. I'm about trying to do the best thing for our patients all the time. And if you have the research and if you have the education behind yourself and the staff that you work with to support that and push it, you actually get respect. You get a validation. People actually stand up and say, actually, okay, yeah, maybe we need to listen. He was right the last time and he proved it and it was done. And that kind of builds on itself and it's incremental and people do actually take notice. And I think if we don't do the education bit and we don't do the research bit, we're losing out on a huge resource. Now, it takes time, it takes effort, but there are lots of people out there who will do it. There are lots of people out there who will do it for free. Anything we do now around nursing in the prison service is researched. We have a number of projects ongoing at the moment, and we've got various organisations and philanthropic individuals who are actually giving us money to pay for PhD students for 3 or 4 years to come in and research what we're doing. The National Office of Suicide Prevention are coming in and researching our self-harm, our new self-harm matrix, because it's filling a gap of stuff that wasn't recognised and wasn't researched before. So again, pull that in, gives you more validation, makes it real, makes it work. And finally, dreams. I think it's so important. I'm a bit of I spend a lot of time in the car traveling around the country across all the prisons, and I daydream on a regular basis. But I think if you dream and you think of, well, what could it look like? What might it be like? Who do we need to make it work? How can we make it work? I never thought, 7 or 8 years ago, I sat in a masterclass similar to this here in the Royal College. And I never thought for 1 minute that I'd be down here one day talking to people like yourselves. I never thought I would have gone back into my master's or did my fellowship with the college, because I suppose, you need to get into that zone to make it happen. And when you do that, and when you try and you make that first step, and you get people around you who can work with you and help you achieve things, it can happen. And I think the more you dream, and sometimes the more outlandish the dreams are, you filter it down a bit, and then you get to something which is really, really good and really worthwhile. And I think all nurses should be allowed of time to not just, I think we used to call it reflection. But I think it's, reflection is kind of looking back at what we did and how we might do things. But I think we need to dream. We need to look forward. This is about visions and about how we really can make it work and how we really can make the difference. And just to make that all really, really easy to remember, it's called busted. And if you do all that, you are busted at the end of it. You're tired. But you know what? You actually get through, and you do, it keeps you going. And it's that thing about nursing, we can be so busy doing things that we actually forget to enjoy what we do and enjoy our work. And, I think nursing is swung over, in a huge way, from doing things to people and for people to doing things with people. And again, it's about, you keep the patient at the centre of what's going on. You're actually doing it with them. And I hate the expression, a real American expression, we're going this journey. Sometimes you get punctured, sometimes the wheels come off, sometimes train jumps the tracks. But it is about how you do that journey with people. And it is, if you don't do that journey and you don't have those dreams, you're never going to achieve. And what you can achieve, and keep going back to patients and asking them, well, what do they want? How would they like it to be? I was so impressed, and I'll be going back and telling people that, to see prisons in both presentations in front of me today mentioned 10 years ago, people weren't talking, no, we're not talking about prisons. We're just not going to mention it. And that just goes to show the change of thinking. The takeaways from today, I would say, always include your patient. Has to be at the centre of everything we do. You can make a difference. Every individual nurse can make a huge difference. No matter what your work environment is, no matter where you're working, you can really make a difference. It's about influencing people. It's not about power. It's not about the director of nursing. It's not about the chief execs. It's about the people you influence around you. And that is, the buzzword in that is, leadership and followership. When you actually think about it, it means an awful lot. It really, really does. Share your vision. It'll never happen if you keep it in here. If you don't put it out there and you don't talk to people and you don't, get people enthused, and if you're not enthusiastic about it and share it, it'll never happen. It'll never go anywhere. Rely on your professional competence. I've had many run-in and locked horns with many people around how healthcare in prisons should be set up and should be implemented. Even to this morning down the High Court before I came here. If you have your professional reputation and you are good at what you do and you know what you're doing is right, and you can rely, you can fall back on your professional competence. One of the biggest examples was we had with our old drug strategy, that any time we said, that a patient was under the influence in prison, their sample had to go to the lab because it had to be lab verified. Well, why? Now what we do is we do near patient testing. It's on the in-cup test that we do, and the nurse records that from their professional assessment, we describe behaviours, their pupils, their gait, their speech, their sweating, whatever. That stands up in court, absolutely no problem. No judge in the country is going to go against that. But for years we were on, it had to be backed up by this, it had to be backed up. No, it doesn't. Let nurses believe in their professional competence. Let nurses practice. And I worked in the UK for 20 years before I came home. And I never heard the expression in 20 years working in the UK where nurses were afraid that they would lose their registration. I hear it every day of the week now. Why are nurses in Ireland so afraid of losing their registration? I find it really, really strange. If you're doing the right thing and if you're working to your policies and procedures, you're not going to lose your registration. It takes a hell of a lot for you to lose your registration. Why are we so hung up on it? As I say, always include your patient and search for those around you that can help you achieve your goals. You're never going to do it on your own. There's people I will ring up, and I know I'm going to be ringing Mary now and going up to Louth. I was going to do a Tommy Tiernan and take off a Louth, but I thought, no, it's such a good presentation, I won't go there. But I will be up to talk because there's so much from that presentation about what we do and how you link the policies in and how you draw it all together. You need to pull people together. And just being from the prisons, and I'm a big advocate around prisoner welfare and prisoner rights, Nelson Mandela said that you never truly know a nation until you've been inside its jails. A nation should not be judged on how it treats its highest citizens but its lowest ones. I think as nurses, that's our job on a day-to-day basis when we work with prisoners. And that's about the whole integration bit. Thank you very much.
Thanks very much, Enda. My thanks to all the three very informative speakers, very interesting speakers. And this concludes the first part of the masterclass. We will break now for a cup of coffee, and it's a chance for networking and to meet colleagues again. So let's say it's about 3:05. So if we say about 3:20, we're a little bit over time. So we'll say about 20 minutes or so, and then if for further discussions you can take them later on outside the room. But in order just to keep to strict time, we'll say 20 past. And the coffee is downstairs in the canteen. It's down the basement, and you're very welcome. So we'll see you back here about 3:20. Thank you.